Thank you for your patience, and we are a little bit late for starting our session. Welcome back. For those who don't know me, my name is Kouloumas. I am the Vice President of Eular, representing the patient organizations. And as you already saw in our opening, the topic of the conference is the patient-centered care. At least in this panel, the patient sits in the center. So welcome back, and I would like to introduce our speaker. It is a great pleasure to have our president, the Eular president, with us, presenting about the patient-centered care and how this optimizes the outcomes. So, Professor Burmester, the floor is yours.
So thank you very much, Mario. And so it's a pleasure for me to talk about patient-centered care. I must say, when I prepared for this talk, I also learned a lot. And as I told you, I wanted to become a psychiatrist when that helps a lot when you envision yourself to be a patient and how to interact, and because that's very important, because sometimes you're sort of blinded as a physician what the needs of the patients really are. So this is a very important subject. And can I get my talk? So let's see. Here it is. And so new avenues for successful outcomes are certainly needed. So you see here, this might be the situation in this cartoon. There is a patient lying down and with a lot of medication. So, of course, we all don't want to take that much medication. And when I make rounds in my hospital, sometimes the patients get 20 medications, and I tell the residents, well, that is too much. You can't possibly give that much. And then they tell me, no, this is for the stomach, this is for the high blood pressure, this is for diabetes, this is for osteoporosis. And many of them are of course, important. But how to deal with these medications, these treatments, and how can we inform our patients, this is, of course, very important. So here, let me put forward the definition of shared decision-making, and I took this out from a British Medical Journal paper, and it says an approach where clinicians and patients share the best available evidence when faced with the task of making decisions, and where patients are supported to consider options to achieve informed preferences. So this is, I think, is a very good definition, a little bit complicated. I will tell you a few details here. So there are 4 criteria for shared decision-making. At least 2 parties, patient and doctor, are involved in the process. They share information, and the importance is share. Both parties undertake steps to achieve a consensus regarding treatment preferences. And finally, they agree on a form of treatment which is then initiated. So this is here are the various key processes. First of all, you have sort of a choice talk that conveys the awareness that a choice exists. So let's say if you are, if someone has experienced, for instance, a sudden cardiac death, of course there's no choice. You have to really take action immediately and start resuscitation. That's quite easy. But luckily, this is not our daily life. So you have first of all, tell that there are choices, and there's either initiated by either a patient or a clinician, and this may even occur before the clinical encounter. So a good example is my wife. Before she encounters and asks me about a clinical decision of, regarding her own health, my wife goes to the internet, connects the information, and then she approaches me. Sometimes I feel a little bit offended that she doesn't go to me directly, but that's the way it is. And then she said, yeah, in the internet I read about these various choices, and can you inform me? So then there is the option talk, and the patients are informed about treatment options in more detail. And then, of course, very important, the decision talk. Patients are supported to explore what matters most to them, having become informed. And there are patients who say, doctor, I'm so afraid of so many side effects, please don't give me so much medication. And even though we inform the patient about possible risks, we have to respect this. And sometimes patients say, well, I want to get rid of any sign of the disease. I don't care if it's very dangerous. I just want to get rid of the pain or of others. So these are different attitudes that you have to take into account. The decision support, that is very important. So it needs to be brief enough to be used by clinician and patient together. It doesn't make sense to have, let's say, hourly talks and finally don't come up with a good solution. It needs to be crisp, and I will come to that later on, and that will be also a factor of our workshop. And it can be more extensive, designed to be used by the patients either before or after clinical encounters, so that the patient at home can carefully read the information, because we all know that sometimes patients in the doctor's office, they're a little bit excited, they forget what they really want, they didn't write it down, and they see the doctor is constantly looking at the watch and waiting for the next patient. So therefore, sometimes or frequently, you need to sit at home and be informed about possible decisions. Then you talk about the initial preferences, awareness of the options. The goal is to arrive at informed preferences. And finally, personal preferences based on what matters most to patients, predicated on an understanding of the most relevant benefits and harms. So Eular and other initiatives have really helped quite a lot in order to put forward a new classification criteria. That is very important, because we want to identify our patients as early as possible. Early identification and early treatment is key. There's no alternative to that. Treat to target. Together with a patient, we must set a target. And a target in, for instance, inflammatory rheumatic diseases is usually remission, which is, I mean, when I started rheumatology, remission was out of the question, was not possible. We didn't have the tools. Nowadays we do, especially if we catch the patients early. And so remission, which means the absence of any symptoms, ideally, of course, on treatment usually, is our primary goal. Tight control. We already talked about this this morning. So the patients need to be seen frequently, or as frequently as necessary and possible, in order to control the disease and adapt treatment. And of course, it is very important to define what remission truly means. So the Treat to Target initiative was very, very important. It is an international initiative that has been updated recently. And among these overarching principles, I will not go into all the details, you can actually download the material for free from the Annals of Rheumatic Diseases. It states as the first actual item, the treatment of rheumatoid arthritis must be based on a shared decision between patient and rheumatologist. So you see, this is already the first overarching principle. And if you then go into the 10 key recommendations, it says the rheumatologist should involve the patient in setting the treatment target and the strategy to reach this target. And I had the honor to be among the panel designing these recommendations, and there was quite a lot of debate. So first of all, the patient, it said the patient should be informed and the patient should know about it, but then we said no, the patient should be involved. So really take active part here, and that is very important. So this is the treatment algorithm that we have. Rheumatoid arthritis is just an example. So it can apply, and I'll come to that later, for many, many other rheumatic diseases. So you have active rheumatoid arthritis. The usual goal is remission, absence of any symptoms, ideally. Sometimes we cannot reach this. Why not? Because it's a long-standing disease, there's already pain going on, there are joint deformities. So then we say, okay, in these instances, low disease activity is an alternative goal, and of course, this needs to be sustained. It's not good if you have a remission for a couple of weeks and then you lose it. So it needs to be sustained, and how do you sustain it? By actively controlling the disease and adapting treatment if the actual treatment fails or is not sufficient. And you see here, shared decision with patients. Whenever you see little asterisks here, and this is very frequent, there is a shared decision point with the patient. So does that work? And we'll just show you one example. It's a Dutch study out of the BEST trial, and they evaluated, does this really work in daily clinical practice? And yes, they could show it in an interesting paper published in Arthritis Care and Research last year. And yes, the rheumatologist, and this was a Dutch study, so we already heard that maybe in some other countries, the mentality needs to be changed. They generally agreed in the Netherlands with this concept and followed a 10-year follow-up, DAS-tiered treat-to-target strategy. So even for 10 years, it worked. So it's possible. Sometimes, of course, and we need to have better tools, there was disagreement with the disease activity score, because sometimes the patient may not feel well because of other factors, while the joints are completely normal. So then the disease activity score might be altered. Nevertheless, you still don't change treatment. So we need to work on this as well. And these results indicate the feasibility, nevertheless, of continued protocol-driven treat-to-target therapy. And for daily practice, adherence to treat-to-target therapy might be improved by adopting the structure components of a clinical trial. And that is very important, because many doctors, and I used to think that myself when I started treatment, I'm a doctor, I have the feeling how the disease is, I don't really need to score something, I know what's best. And nowadays, I feel that you have a structured approach. Even if you're a very experienced doctor and you say, this disease activity score is too high, even though I might not want to change it, I must do it because it's for the best of the patient. So like you do in a clinical trial, where you're basically forced to follow the protocol. And I fully agree with this notion, and our Dutch colleagues even went so far, and we can discuss this later, they let the computer decide in the clinical trial what was best for this particular patient. So, next it is, there are further initiatives treating spondyloarthritis to target, and treating lupus to target, and very soon treating gout to target will also be out. And we in Germany have designed a new way, which is now called treat-to-participation. I will not go into the details of it, but it is so that the aim is that the patient is informed and can participate, not just treat to target, but treat to participation. So how is this achieved? And Eular, as you all know, is working hard on management recommendations. And you also know probably that in all these initiatives, there need to be at least 2 patients to be present. One is, for instance, Marius, I see him very frequently, and Martin de Witt, for instance, and other patients are present, and they help us a lot. Sometimes when they say something, we say, oh, really? We have to think about it as physicians. But of course, and that's easy. In a university setting, and I'm a university professor, there are 2 parties that are always right: the students and the patients. They're always right. So it's that easy. So even though you may have a different opinion, but you, of course, have to respect what they think and integrate this into the recommendations. And that's what we do. For instance, here we have the Eular rheumatoid arthritis treatment recommendations, which, as we sit here, are currently updated. Marius knows the process. We just came back from Vienna for 2 days, worked on these new recommendations, but based on these former ones, and this will not change. You see again, treatment of RA patients should aim at the best care, and even stronger, must be based on a shared decision between the patient and the rheumatologist. This is the Eular situation. If you look into the most recent paper published by the American College of Rheumatologists, I carefully read the paper, and I put in the search machine shared decision. Nothing came up. Actually, it's not present in the American paper. But what I found in this paper is, and that comes a little bit closer, is this sentence: these recommendations which focus on common clinical scenarios, should be used as a guide for clinicians treating RA patients with a clear understanding that the best treatment decision can only be made by the clinician and, interestingly, in discussions with patients. You see, different approach compared to the Eular situation where we say participation and shared decision. They said discussion, whatever that means, taking into account their risk-benefit assessment, including consideration of comorbidities and concomitant medication, patient preferences, importantly, and practical economic considerations. So they're not, in my eyes, even though I was trained in the United States and I highly respect my American colleagues, but I think they haven't advanced that far as we have at Eular, where we take this probably even more serious than our American colleagues. Now let's have a look, because there are people who say, well, shared decision, it's very complicated, should we really need this? Is there any evidence that it leads to a better outcome? And that is, of course, a matter also for the health insurance companies and the payers, because ultimately, shared decision needs resources that are taken out of the entire budget of the healthcare system, and the payers may ask, well, does it really make a difference? Does it change outcome? And for those of you who are interested in that particular research, this is a paper which you can freely download from the internet, from the German Doctors Association's journal magazine, and that investigated outcome-related effects of shared decision-making. I cannot, as a systematic review, quite interesting, and there are, and you don't have to go into the details of the table, there are studies in which the intervention improved patient-relevant outcomes compared with the control group. So 50% basically of the patients were informed, took part in the decision, so it was a shared decision process, and 50% of the patients didn't have that opportunity. So now you compare, was the outcome in group A, shared decision, better compared to group B, where there was no shared decision. And here you see examples like diabetes, ulceration, breast cancer, interesting, even schizophrenia, which is quite interesting, bronchial asthma, arterial hypertension. Yes, it made a difference there, but there were also studies in where it didn't make a difference, like prostate cancer, patients' antithrombotic treatment, depression, and others. So we still need a lot more evidence and a lot more studies in various diseases in order to come forward with the best possible ways to implement shared decision in improving outcome. So many drugs we have now, and of course, we can only make a good decision if we have decision aids. And you see here already the multitude of drugs that we are confronted with in rheumatology. And if I say rheumatology, we are not just rheumatologists, we are internal medicine doctors. Our patients have diabetes, our patients may have hypertension, they may have other diseases that we need to take care of, hyperlipidemia, and so on, and we need to take care of this as well. So in some ways, a rheumatologist is also a family doctor. And that is the beauty of our discipline. We are not just interested in the heart and no other organ. We are interested as a rheumatologist in the entire person. So no shared decision making without decision aids. So it can be a communication between doctor and patient, between health professionals and patient, and that is what I believe is extremely important, the communication between the health professional and the patient. Because you all know, let's say I have about 15 minutes for a regular visit for a patient with a rheumatic disease, not more. 15 minutes because my schedule is so full. So can you convey all the necessary information there? No, you can't. So therefore, you need additional tools, and I strongly believe in the communication between health professionals such as a nurse and a patient. It's sometimes amazing if you talk to the nurse later, you say, yeah, the patient informed me about this and that, the patient had this and that question that the patient never addressed to the doctor because the patient was too excited, was afraid that the doctor was in a hurry, other reasons, so therefore this is very important. Communication among patients in groups is very important, and that's what we're sitting here because we have the patient organizations who inform themselves about the best possible treatment. Communication in the family may be very important. Sometimes it's unfortunate because I treat a patient with a certain drug and the patient comes back and says, yeah, I like that drug, I would like to take it, but then my son said this is poison, don't take it. So I'm not going to take it. So because the family is influential, and you need very frequently also inform the family and ask the wife or even the children of the patients to come along and inform them as well. And then you have information materials such as leaflets, books, TV broadcasts, internet-based material. Why is that necessary? Because the patient and also the physicians are overwhelmed by the package insert. You see, I took a photograph of a package insert for a biologic. This is only one page. You can turn it around and you have another one. I put a ruler of 30 centimeters there so that you have about 70 centimeters of information in fine print. Can you really deal with this? It says about 40 general side effects, about 40 side effects from clinical trial. So all in all, 80 potential side effects, of which only 1 or 2 may be really important. So you really have to condense this information, which we are doing in the German Society of Rheumatology. Then, of course, and you see here, I translate this cartoon. I'm proposing a trade-off here, says the doctor. First, you report in 5 minutes what your magazine tells you, and then I'll tell you what I recommend. And this is also a frequently encountered situation. Patient comes into my office, shows me a magazine article, maybe completely reasonable about a new treatment, or completely crazy because it's a very strange treatment with sea urchins or whatever, and it's not so easy to inform the patient that this may not be the best possible treatment in this case. But it takes time to talk about this. Or this cartoon here, to make your decision easier for or against this treatment, the doctor says, I will now inform you about the results of the most important multi-center randomized double-blind trials. And you see the multitude of information that is present. Of course, we have hundreds of papers informing us about all these biological treatments. We have 9 biologics. Each biologic has at least 10 papers or more. And to condense this information for the patient is, of course, very important. So the Eular School of Rheumatology, which we will launch very soon in June at our annual meeting, might be a new avenue to generate, for instance, decision aids. So let me give you a little bit of a background. So there is a steering group consisting of myself, Hans Belzma, and Anna Maria Janocco and Gabriela Kluge from the staff. And this is based on our goals of Eular. We want to really be the preeminent provider and facilitator of high-quality education offerings for physicians, health professionals in rheumatology, and people with rheumatic and musculoskeletal diseases. So we formed the school, and we have several classrooms, like in a real school. Medical students, teachers, trainees, rheumatologists, you see colleagues involved who have expressed their interest in teaching and generating educational material. And of course, there's also the group of Pare, you see here, and Dieter sitting there. He's a teacher by training, he's a real teacher. I think in geography, Dieter, is that correct? Yes. And some other things. And of course, I think he used to teach geography in English. Is that correct? Because his English is, at least in my eyes, nearly immaculate. And so there are Dieter and other colleagues involved. I think they're all here. So at this meeting, and so we can generate the best possible material here. For instance, enhance the patient partner program, which is very, very important to the development of rheumatology in general. And we would like to create a website, install a Eular portal, and of course, also for the health professionals, it will be important that we have a Eular certification and point system, so that if you encounter a physician who has maybe 50 points, at least you know that this physician has been well trained in rheumatology, because otherwise the physician wouldn't have that many points. So the key messages, and we will allude to that, to many of these aspects in the workshop as well, are if treatment adherence is enhanced, clinical outcomes can be improved. Because the worst drugs are those that the patients don't take because they are ill-informed and are afraid of a potentially very good drug that is necessary to keep the disease under control. So adherence is key, and a key to adherence is shared decision. So it can be optimized by patient participation. Shared decision is considered now a gold standard in patient participation. It can have a positive effect on patient-relevant disease-related outcomes, even though more trials and better trials are necessary in order to implement this. And the studies, as I mentioned, available so far, indicate a need for minimum standards regarding the implementation and investigation of shared decision-making, which is very important, and also to convince the payers and the health insurance company that this is an instrumental and key part of our daily life in the best possible care. So thank you very much for your attention.
Thank you so much, Professor. Please join us to the panel. Really excellent presentation. I think that you have set up the scene and you gave us a good base for the later discussion. So thank you so much for that. So we're going to have our panel discussion now, and I would like to introduce to you our panel members, and allow me to start from the ladies on my right. So we have with us Boryana Boteva from Bulgaria. She's the Vice President of the patient organization. And we have our Professor Stoyanka Vladeva from Bulgaria, representing the Rheumatology Society. Thank you for being here with us. And we have Christina Opava from Sweden. She's the Vice President representing the health professionals. And we have on my left, Wiek, the Chair of the Standing Committee of Pare, and our Eular President, Professor Gerd-Burmester. So welcome everybody, and thank you so much. And I would like again to start from the ladies first and from the left. Just the first statement, and please, a very, very short. What is the most important element for you, from your perspective, of the patient-centered care?
Thank you. Does it work? Thank you for your question, Marius. As a patient myself and as a patient representative, I think that the most important is the care to be individual, caring about the needs and the preferences and the values of the patient, and also to be coordinated. For example, you know that rheumatic diseases are connected with a lot of comorbidities. If we need to visit another specialist, we would like our rheumatologist to connect with the specialist, to talk, to discuss. And that, in that way, I think that we as patients will feel that we are cared enough, and we have personalized care from our rheumatologist.
Thank you very much. Please, Professor.
For me, it's very important this update version of the treat-to target recommendation for the rheumatology practice, because the education of patient is very respect, greatly improve the contact with doctor, and I would like to repeat that in our country it's possible to meet the team with patient organization, rheumatology expert, and presenting from regional health inspection to this team rheumatology group who made the center care of patient of rheumatic disease in our country.
Thank you. So, from the health professional perspective, what is the most important, Christina?
Yeah, I would say that As we heard, treat to target does not always lead to remission. And even if remission is reached, not all the symptoms are always gone from the patients. And thus, there are other health professionals that can be involved, of course. And I would also say that shared decision-making about drugs is not the only thing that person-centered care means, but it also means education and exchanged information. And I think that health professionals have a very important role here. And as we heard Professor Burmester also say that if you listen to a nurse or to a physiotherapist who has more time with the patient, then the care will be more person-centered. So one thing that wasn't on the slide, but that you actually said, was that not only communication between doctors and patients, health professionals and patients, but also between health professionals and doctors.
Thank you. We have another microphone. So, teacher, as a chair of all the organizations representing 120 million patients in Europe, so what is your highlight?
I would just like to concentrate on the shared decision making. I think it's about 2 years ago, I went to a conference of DGH in Germany, and there was a panel discussion also then, and the question was, are you going to include patients in that decision? And they could give a vote, it's technically possible, and there were only a little more than 50% who accepted that. They were mainly GPs. I think that's the reality if you think what is happening yourself. Why does that not happen? I think we must be fair. There are lots of obstacles why this does not happen. One obstacle to my mind is the reimbursement system, at least in our country we've got. So there's some other obstacles as well. So what can we do? To my mind, there are two things. We could, as a patient organization, we have one target group, that's our patients. Empowering our patients that they are really informed. We saw that on the slides, what patient organizations can do. And that they, well, when they go to their doctor, that they really can ask the questions, that they really can respond, and that they do not sit the way those two patients were sitting. If you remember that cartoon, one was really down and the doctor was up. So that there's really this kind of equal level. And the other thing is, to my mind, that we really support patient organizations, that they have got the material, that they have courses for their patients, so that they really are supported. And this aim is really achieved that we can say not 50%, but let's say 80 or 90% really participate from that shared decision making.
Thank you, Dieter. So, Professor Burmester, I would like to ask you and to have the hat of the president of Eular, representing more than 100 organizations in Europe, and as you said, unique because you're representing care professionals, patients, and clinicians. So, from your perspective, what is the most important that maybe Eular can do in order to promote the patient-centered care?
First of all, Eular will and must generate the spirit that this is really essential. As Dieter already pointed out, many physicians, not so many in our country, but maybe if you do a secret vote, it may be different. It was a secret vote, and people tell what they really mean. Because if you ask them, everyone will say, yes, of course, it's very important. But you need to generate the spirit, and as we just learned, that the spirit may not be always present in countries like Bulgaria, and that, of course, Eular can help to generate the spirit in all the countries of Europe. But not only Europe, we will help also the Asian and the Latin American and other colleagues as well. I think that is, Eular can be at the forefront, so that everyone accepts that shared decision is really essential, which would already be a major goal. And secondly, Eular can provide the means how to generate shared decision. And I think there's no shared decision without decision aids. That is very important. And so if you look into, because there were recent papers in the New England Journal of Medicine and so on, there are procedures, cardiovascular or cardiology procedures, where you can either have a device in your heart or you can do medical treatment. So this is not an easy decision, not even for the physician, to say, well, do I need surgery or do I just take some drugs? And what is the best for me? And so there, the colleagues in cardiology have generated very nice decision aids informing you about the procedures, about the alternatives, the pros and cons. And that is what Eular can do with the Eular School of Rheumatology, because, I mean, we take care of 200 diseases, and we take care of, we have so many, luckily, treatment options, and rightly, they do not only include drugs or surgery, they also include physical therapy, which is very important, occupational therapy, spa treatment, and others, and that is also an essential part of the information. And also we have, I don't know, probably more than 20 languages to take care of. That is also very important. Of course, this is a challenge, this is sort of a barrier, but also it's an opportunity for Eular together with the local organizations to have translations. And because many people say, oh, this is very difficult to translate it, but this currently, as we sit here, everything we are saying is currently translated into Bulgarian by a simultaneous translation. So it is, of course, it is an effort, but it's possible. And we need to open up our minds to not say this is a problem, will never work, because we must attend and direct our attention towards solutions. And I'm not a fan of complaining, because rheumatologists like to complain a lot, and rightly so, but that doesn't help us. We need solutions. And solutions can be provided in many ways by Eular, since we are in the unique situation, I stress this again, of having the three pillars of patients, health professionals, and physicians. And this is a prerequisite nowadays to have the tools for shared decision making.
Thank you so much. So just to remind our friends who are joining us through the live stream, through the website of Eular, that they can send their comments and questions just using the Twitter and the hashtag Pare 2016. And now, of course, the floor is open for you for any comments, questions. Please just take the microphone, state your name, your country, and your question. And I like to ask you to be very short because we don't have much time for that. Yes, I have a question from Florian from the Twitter. Yes, Florian.
Thank you, Marius. We have received two questions via Twitter. One is, what happens if there are more specialized clinics involved or specialty doctors? For example, if you're going to do two different clinics, how can you enable shared decision making if in one clinic you're regarded as an arthritis patient and in another one with another disease? And the second question was, should the concerns of increasing cost of medicines be also part of the discussion on shared decision making?
Okay, who wants to answer that?
I maybe can allude to the first question, because this is a frequently encountered situation. I would definitely not say problem, because you need, as a rheumatologist, you need to create a group of friends that you have in pulmonology, in orthopedic surgery, in neurology and dermatology. That is essential. And they shouldn't be just specialists, but they should be friends. And that is very important, because there is no competition. And usually the rheumatologist should be the pilot. And the pilot will, of course, need information from flight control, from the weather system, and so on. And the pilot will collect this information and then will have the best possible path leading to the final destination. And that's how we do it. So whenever a patient has a dermatology problem, I know, oh, this person is the best one, and I will ask the person, please inform us about the patient, and then I'll discuss it with the patient and together with the specialist dermatologist to find the best possible way.
Thank you.
May I add one thing concerning that? I think this really happens, to my experience, if you've got a clinical setting. And that's the problem. But if you haven't got that, that is not available, then there is a difficulty. The difficulty is that information is exchanged, that really cooperation happens, and so it is fantastic if you've got that, a clinic, and you have got these friends working together.
May I just comment? But of course, if you are, let's say, a doctor practicing alone or together with one or two colleagues in a practice, it's more complicated. But also these colleagues usually have a group of friends who are also dermatologists, close by, neurologists. But it's more complicated because it takes more time until you have seen the other neurologists, until there is feedback. And that's why we see in a very complicated and critical situation, we see the patients in a clinical setting in order to speed up things.
Thanks. So, any questions, comments? Yes? Here. A microphone, please.
This is Raj Mahapatra from the National Ankylosing Spondylitis Society in the UK. In the healthcare industry, we have the concept of the payer, and the payer is either the insurance company or sometimes it's a governmental agency. Often, I think that one of the reasons why you have a challenge getting patients involved in healthcare discussions is because the patient's taken out of the picture because the payer is seen as insurance companies or government agencies. Whereas actually the reality is the payer is the taxpayer who pays the government to pay the pharmaceutical companies, or it's the insurance premium payer who's paying the insurance company to pay the healthcare bills. Do you think, at the moment we have a move away from national healthcare systems into insurance-led healthcare, do you think that this will help or hinder patient-centered care?
Who wants to answer that?
Yeah, I can let's say address part of it because it's a very complicated issue because you have so many different healthcare systems in Europe, and so therefore the Bulgarian healthcare system we learned today is certainly quite different from the German one, from the French one, and as you pointed out, the British one, which is basically taxpayer paid, while in Germany we have 100 health insurance companies, and each one has a different attitude for payment. Some health insurance companies have a great program in educating patients, they support it, and some are not interested at all. I think what we need to do, and that takes, as I mentioned, a lot of work, is to convince the payers, the health insurance companies, for instance, that patient-centered treatment and shared decision is leading to a better outcome and stronger adherence, and then they will eventually save money. Because let's say for instance, this one example, you can now cure hepatitis C, but the costs in Germany are 50,000 euros for the cure of hepatitis C. So the health insurance companies in Germany have said, yes, we agree to this enormous amount of money. However, we're quite afraid that the patients don't take the drug that we pay for. So for them, adherence is extremely important. Imagine you pay such a lot of money, the disease is not cured simply because the patients don't take the drugs. So there you can easily convince the health insurance companies that shared decision in an hepatitis C setting where the patient must consent to the treatment and take the treatment regularly, which leads to a cure, however it is very expensive, is a good thing. And these are the examples that you need to put forward to the health insurance companies to really take it to heart and eventually reimburse it as well by schooling and by giving enough money to a discussion with the patient, which currently is not the case.
Thank you. Christina?
Yeah, I would also like to comment that now that the drugs are much more expensive, there is also a reduction in rehabilitation, as we heard even for Bulgaria previously today. So from maybe 4 weeks to 1 week, or in special cases 2 weeks. This means that healthcare professionals in rehabilitation need to work in new modes. It couldn't be any longer them making the patients healthy again, but they have to give the patients tools to self-manage much more. And that really calls for person-centered care, because you can't make someone self-manage without taking into account their whole life situation. So I would say maybe if we work more efficiently and cost-effective, it requires a more person-centered care.
Thank you. Yes, please.
Thank you. I'm Ella Vine. I'm a board member of ENFA, European Network of Fibromyalgia Associations, and I'm chief executive of the UK's Fibromyalgia Action UK. And I just wanted to refer what Raj just said about the payers, whether they're like local trust or insurers or governmental organizations, whatever they are. I think that the payers should include some patients' representatives on the payer board. In whatever country, in whatever shape and form those payers are, I think it would be very good to campaign perhaps for that. So patient representatives must be included in those payers. And another thing, with this notion that patients don't take drugs, so therefore there is that excuse for politicians and the payers and others not to offer drugs. In the UK recently, there's an example, the Health Secretary Jeremy Hunt used this, and that's kind of like a political, basically, talk, to kind of blame the patients that are not taking the drugs. But I think that's not fair, because the patients want to do everything to feel better and to get better, and to use this sort of notion to kind of switch the blame, where the general population may not understand what invisible disability is. It's really dangerous, and it's something, used sometimes by politicians and the others for a purpose, and I think we have to be careful with that. Thank you.
Thank you. So patient participation is very important, also for the design and implementing policies in health. Yes, Boryana.
To comment that point that you proposed patients to be included in the health insurance. I can say that in Bulgaria we have in fact a patient representative in the National Health Insurance Fund, but I must point that we should be careful, because if there is just one person, it is he can become, how to say, not independent. He will be not independent. Maybe we should be careful when we want to be included in these health insurance funds, for example, or we should have a lot of representatives who can change in order to stay independent. So we should be careful.
Okay. Thank you. You want to comment on that?
Just one remark concerning adherence, I think, what you said. Adherence, there are lots of surveys, I think they show that sometimes there's only an adherence of 50% or 60%. But we must be careful. The matter of adherence is not only based, let's say, on this patient-doctor relationship. If there's no adherence, there are many factors why it is like that. And I personally feel that the patient himself must be also seen as an individual, and the patient is responsible. Certainly we must, as we said before, empower patients, but nevertheless the patient is responsible, and if he sees that, well, I will not take that pill, then please go to the doctor and say, well, it does not work. I don't want to take it. Why is it like that? So what I do not like personally is that all kinds of responsibilities are then given to others, and the others are in charge, and not I am personally in charge. This is my opinion.
Okay, thank you. Of course, sorry, but we have extended our time, and I know that we follow and we have more time for discussion in the workshops. Actually, the workshops is the place that for all of you can be very active contribution, and the place that you can discuss all these things. I just want, we have already extended our time, but I think that we like to have a final word, a final remark statement from all of you before we close our panel discussion. And we start again from our lady on the right.
The hardest part to start. What can I say? I believe that patient-centered care can be achieved by partnership between doctors, patients, patient organizations, health professionals, and institutions. That's what I can say.
Thank you. Thank you, Boryana. Professor Stoyanka?
Yes,
a very final remark.
The dissemination of this new recommendation and new approach as well healthcare professional, doctors, and support patient and carer to manage their diseases.
Thank you. And of course, we're looking forward to collaborating together, maybe translate recommendations in Bulgarian for the Bulgarian patients. Yeah, thank you.
Yeah, there's a lot of small talk going on between health professionals and patients while preparing for infusion therapy or in a hand exercise group. And all of that small talk helps patient-centered care or person-centered care. So when you share information there, you form a basis for person-centered care. So don't forget about that information that health professionals have.
Thank you, Christina. Dieter, your final remark?
I almost forgot. Well, patient-centered care means for me there are different people, different groups involved. There are the GPs, the rheumatologists, the health professionals, physiotherapists, and so on. And what I would like personally as a patient, that, let's say, there's more exchange of thoughts, of ideas, that there's more cooperation, because this helps the patient, it helps the outcome, and it really saves money in the end. So that's why I'd like to have that this is really improved.
So it is a win-win situation. Thank you.
Yep. I can only agree to that and echo these remarks. I think shared decision is key to best possible treatment. In the end, it will save money, as Dieter already pointed out. We need just to make that clear to the payers. Nevertheless, we need modern tools for the best possible education. That means decision aids, and hopefully Eular it will be possible at Eular to provide the best possible tools for all the patients that we take care of.
So thank you so much, everybody, and I think we deserve a warm applause for our panel members for this discussion. So, very quick, I would like to introduce to you the next workshops. So, in your registration form, you remember that you have indicated your first choice and second choice of the workshop that you would like to interested to attend. We make all the efforts in order to accommodate this, but of course you have understand that we have also many people register for a workshop, and we like to give an equal numbers for all the 4 workshops. So we did the best in order to accommodate your registration preference for the workshop. Please check outside of the room. There is a list of each one of the workshops, the participant lists. Please check that in which one you have registered. And please be aware that we don't accept any swap of the workshops. So you have to go to the workshop that you have indicated in the participation list. Because we want the number of the people attending these workshops. So all the breakout rooms will be in this floor. So we're going to have a workshop here, and the other 3 workshops will be in the breakout rooms on the other side of the building. So it's nice that we have all the workshops rooms in this floor. So this is the workshops, and please check outside in which one you have registered. So after the workshops, please go to the lunch, which will be served in the restaurant of the hotel, in the Seasons restaurant. Please be sure that you return to this room for the workshop feedback at 14:15, so 15 past 2, in order to start promptly at 2 o'clock, 20 minutes. So now, please, everybody, I know that we have short time. Please be sure that 11:50 you will be in the room ready to start the workshop. So, thank you so much.
Okay. Das ist eine schöne Nachricht. Ja. Ja. Gutiert sich auf jeden Fall. Auf jeden Fall. Ja, ja, na klar. Genau. Nö, genau. Na klar, na klar. Zumal wenn ja, nee, das ist ja. Zumal wenn wir das ab und zu machen. Das ist ja noch leichter. Nee, da bin ich absolut sicher. Ich kenn das. Ja, ja. Ich kenne das ja auch gut. Ich mache das ja auch immer ganz gerne. Genau. Okay, nee, das ist okay. Ja, ja, genau. Ja, ist klar. Genau. Gut, ja, dann freue ich mich und dann auf die Zusammenarbeit.